Hi, everybody, and thank you for having me here today. I'm very excited. This is my first, actually, trip to Turkey, so I was very grabbed onto the opportunity to come and visit a very friendly, hospitable country. I'm originally from Lebanon, not too far from here, but I have been in the U.S. for 25 years. And initially, I started kind of in the upper northern part of the U.S. in a kind of a rural state, Iowa, and then moved down to Texas in the south of the U.S. About 10 years ago. I have no conflicts of interest to report. And I thought I'd like to talk about pediatric depression. I'm a child psychiatrist. I have been a child psychiatrist for a long time. I do mostly research, actually. Most of my time is in research, but my research is clinical research. So I see a lot of kids and their families. And, you know, over the years, I've realized that depression is probably should be one of the easiest diagnoses to make, given how prevalent it is. But I've continued to struggle to make the diagnosis in a way that's convincing to me. Of course, at a time when we still don't have a test, whether it's a blood test or imaging test, that gives us the diagnosis. So what I would like to talk to you guys about today is some of the challenges that at least I feel have come across in assessing the depression in children and adolescents, and talk a little bit about how depression manifests in kids and in teenagers, and then, you know, how to manage the condition. I've set up the talk to take about maybe an hour and 10 minutes. I know we have a little more time than that. I can spend more time talking or less. If questions come up and you want to interrupt me, I don't mind it. Actually, it might allow for more of an interaction, because I might say things that may resonate with you, or I may say things that you completely disagree with, in which case I'd be either way, I'm interested in kind of your thoughts and your opinions about this. Also keep in mind that though psychiatric conditions have been shown to be prevalent across cultures, across countries, across, of course, the age range, there is a significant cultural component as to how they manifest. And I've never practiced. As I said, I've come to, this is my first trip to Turkey. So it may be that you guys are exposed to a particular manifestation of depression that I'm completely unfamiliar with. And again, I'd be extremely interested in your perspective, in part because some of my research relates to depression. I mentioned a little bit that I've been a psychiatrist for 25 years, and back in Iowa, in the northern part of the United States, I staffed an inpatient unit, so I've seen kids being admitted for management of depression, typically suicidality or self-harm behavior, in an inpatient context. Of course, I've also practiced in an outpatient setting. I do a lot of research, as I said, so I've seen kids within that context as well. And CL stands for Consultation Liaison Service. I don't know what you call it here in Turkey, but essentially it's the consultation service where we get consulted by other services. Now, for the last 10 years, even though my academic affiliation is Baylor College of Medicine, My clinical affiliation, so the hospital where I work is Texas Children's Hospital, which is kind of varies between being ranked second and third in the United States, but it is by far the largest. It's a massive, it's probably worth, I don't know, 10, 15 billion dollars. I mean, it's very large. It's now composed of 6 or 7 hospitals. Each hospital has multiple buildings, I mean, it's really extremely large, and they serve now, I don't know, about 1 million families or something. It's very, very large. Having said that, as you will see throughout the presentation, I know a lot about depression, but I still struggle a little bit about how to come to a diagnosis, especially I know from what I heard yesterday, my discussion with some of the colleagues here today, you guys are very busy. And so when you have 15 or 20 or 30 minutes to see a new kid, it can be quite a challenge to reach a valid diagnosis. So in the United States, of course, we have the DSM, and I heard some, again, presentations yesterday and today mentioned the DSM, so perhaps you guys here use the DSM more so than the ICD, which would be a relief for me, because then I don't have to worry too much about the ICD, which I know virtually nothing about. With the DSM, of course, the way we define depression is that you have to have at least 5 out of the 9 symptom criteria, and they have to be present for most of the day, most of the criteria. It's not just a passing, feeling of depression. They have to be present for at least every day, for at least a 2-week period. And one of the 2 criteria must be either depressed mood or anhedonia, loss of interest, so the first 2. All of them could be based, all the criteria could be based on patient report, except the one related to psychomotor retardation activation. It has to be observed either by an informant or by the clinician themselves. Again, what the criteria emphasize, which is not always kept in mind, is the pervasive nature of the symptoms, meaning the symptoms have to be present and present consistently, not just, here and there. And including thoughts of suicide, they have to be recurrent. We mentioned, the fact that the symptoms have to be present for 2 weeks. And I'm happy to, I know a little bit also about how these criteria came about. If anybody's interested, I'm happy to discuss them. The one thing that is a little arbitrary was the 2-week period. Otherwise, the other symptoms were a little more thoroughly established. The one last point is the symptoms have to represent a change from baseline. For me, as a child psychiatrist, seeing someone who's 10, 11, 12, even a little older, that can be pretty tricky, change. Because many times when you're dealing with a child who's coming to you with symptoms of depression, oftentimes the symptoms have been there for actually quite a bit of time. And we'll talk about this a little later. And so at what point do you say this is a change? This can be quite challenging. Of course, the reason why all of this is relevant is because I want to know that when I'm prescribing a medication which was studied in a particular condition for a particular condition, that the patient I'm seeing in the clinic or on the inpatient service actually fits broadly those criteria, and the findings will apply. You guys, I don't know if you want to take a quick picture. If you don't have these symptoms memorized, no offense to anybody. I work with residents and fellows all the time, And yesterday, a couple of the talks that I attended mentioned how, especially the morning talk, the speaker talked about how because clinicians are rushed, they often bill based or give a diagnosis either based on what maximizes billing or what they can justify given the short amount of time that they have. And so one really challenge, one of, we use the term pet peeve, one of the things that frustrates me working with learners in the US is they're rushed. They don't want to take the time to actually assess thoroughly for the symptoms. And as such, many of our diagnoses used to be with DSM-4, not otherwise specified. Everybody is NOS, NOS. Now it's unspecified. And actually, DSM-5 changed that terminology from not otherwise specified to other specified or unspecified to force people to start using those diagnoses less, but it doesn't matter. They still use them equally. So the point is, take a picture if you don't memorize these, if you haven't memorized these symptoms, because I'm going to ask you about them as we go along. And I might, point to people just to put people on the spot, make you guys nervous. So I'm going to, throughout this talk, I'm going to talk about Bella. This is a real kid. Again, I'd be curious about some cultural differences you might observe. But this is a real kid. I didn't make up anything. And as we go along, as I describe her case, I'll point out some challenges that arise. So she's about 12 years old. You can see she's a little on the shorter side. That's because she's of Hispanic origin. And the normative data in the US were based mostly on Northern Europeans, so they tend to be a little taller. SMR is what you may know here as a Tanner staging, so sexual maturation rating of 2. She hasn't had her first period yet. For the most part, she's medically healthy. She lives with her mom, 15, 20-year-old sisters. I don't know the rate of divorce here in Turkey, but of course in the United States, about 50% of marriages end in divorce. So it's very prevalent to see a single parent household. The parents separated when she was 1 year old, so a long time ago, because of dad's violent temper. I put this in because, of course, everything's relevant, not just exposure potentially to trauma and living in a single-parent household, which adds complexity and stress, but also because dad's temper is relevant. Most likely, it reflects some kind of what we call in child psychiatry, at least in the US, externalizing disorder. Whether it's ADHD or conduct disorder at his age, maybe ASPD. These are her exact words. I feel sad because I think people don't really like me. You can see as she hits puberty in the US between ages 10 and 13, before kids are labeled as a teenagers, we call them tweens. So in that transitional phase, I know most of you may be familiar with that, so forgive me if I'm telling you things you already know. You can see at this age how especially girls start developing this, becoming self-conscious. Many studies have shown that as girls hit puberty, their self-confidence goes down. And the reverse happens with boys when they hit puberty and testosterone goes up, whether justified or unjustified. Their self-confidence, of course, you can't talk to a guy and not feel like you're talking to, to God Himself. So you can see the self-consciousness emerging. My sisters tell me to go change because my shorts are too short. If I don't do my chores, I feel lazy. My dad calls me bro. Bro is short for brother, and doesn't treat me, it's kind of like a street kind of way of guys calling each other, hey bro, and doesn't treat me like his daughter. I'm scared for my little sister. So dad remarried and is in a relationship and has already been abused, as you'll hear, has already abused his second wife, and he has two little kids. And she said he drinks his problems away. Again, talking about externalizing disorders, substance use is one of the disorders within it. I like, over time, I've developed my own way of asking questions to get, again, to the validity question of the answer. By validity, I mean how correct are the answers? And I'm sure you guys are very experienced clinicians, so I'm sure you can tell sometimes people say things because they think that that's what you're expecting for you to say back. So it becomes very hard to know where the truth is. So I cannot ask an 11-year-old, how's your self-confidence? I mean, I think it would have kind of no real meaning. Instead, I ask them what they like about themselves or what they like to change about themselves. And then she says, I don't know, but she doesn't like her height and that I'm different from others, like the way I dress, remember the short shorts, and talk, I'm too annoying. And then you see what's called experiential avoidance, where they try to avoid uncomfortable feelings by making themselves think of something else, but then the thoughts, of course, are hard to push away. So you see a little bit of, these, what we call perseverative thoughts. In terms of touching on anhedonia, she is able to have fun, but then if I mess up, you see, again, without me asking about self-confidence, you see the guilt and lack of self-confidence emerging and affecting her ability to have a full experience. In terms of attention, you see how the thoughts, the perseverative thoughts, distract her. I'm always also intrigued when I'm asking about suicidality and people say, not really. It's like when you stop and think, well, what do you mean not really? You either think about suicide or you don't. You can't be on the fence about it. And so for me, I take this to mean, yes, they just need a little more support to actually talk about it. Of course, suicidality, of course, in families that are religious, it comes with a lot of judgment because, I don't know of any religion that sanctions people killing themselves. And so my interest is not to make them feel like they're going to hell. My interest is to really know what's going on without feeling judged so that they can open up. Because people don't think about suicide because they're terrible. They think about suicide because they are suffering. And you can see that, with some encouragement, she endorses passive SI. And it's always reassuring when you hear that they were comfortable enough to discuss some of the thoughts with their parents. And that there is a protective factor for suicide is feeling you belong and feeling someone would care. She feels guilty when I don't do something I'm supposed to. So as you can see, I don't know if you're checking off the boxes, she checks off virtually every box. But then she doesn't have what we call neurovegetative symptoms with regard to appetite and sleep. In terms of developmental history, she was born at term, no exposures, no complications, met her milestones on time, we talked a little bit about dad's externalizing history, and he had physically abused the sister, and so she received some care. So I mentioned the checklist earlier. Who does not think she is in a major depressive episode? Does anybody disagree that she has depression? Okay, I'll take. Oh, you disagree?
Is it mainly
Yeah, well, very, very good questions from a seasoned clinician. Um, yeah, so she, I mean, her mental status, at least when I saw her, was consistent with, she was tearful, she was down, and if you come this afternoon to, or this evening to the talk about interviewing, you might even get to hear a little bit her, because I have some recordings. But in terms of getting collateral information, we're just gonna have to hold on. We'll come back to this in a few slides about how she is the rest of the time and based on someone else's observation. Again, I apologize because I'm not familiar with epidemiological data here in Turkey, but in the US, the rates of virtually every condition has been tracked for years and decades. And for, if you notice the citation here, reference, it's an old one. I kept it on purpose. Showing that for decades, really, since the 40s, the rate of depression has been going up. The rate of treatment for depression, it's not just like people are just saying, oh, I'm depressed, nothing is being done. How often people are seeking treatment for depression has been going up as well. And I wanted to point this out and keep the reference of 2001, because do you guys remember when iPhone first came out? What year was it? Come on, you guys. The younger people. Maybe you were not born yet. Anybody? Speak up. Come on, guys. iPhone, Google it. I don't care. Can't you Google it? 2007. 2007. So this has been going on long before the internet, long before social media, long before computers and smartphones and whatever, gaming. It's been going up. So yes, I'm with you. I think social media has contributed. It's not the only thing. This is from a more recent assessment showing, from 2015, showing the rate of depression in kids overall, and the part in color is the part with serious impairment, and then the top part is without. And so you can see that depression is pretty prevalent, of course, much more in females than in males, and it's kind of true across the spectrum of racial groups, and increasingly, as you go up from early teenage years to later on. In pre-pubertal kids, the rate of depression is much lower. Developmental features, so irritability is a significant feature. Whether this would be consistent with the MDD or not, of course, you're going to have to assess for it. And this is where how you apply the criteria would be extremely important. Before the 1980s, actually, people did not think that that kids can get depressed. And that is, and this might seem ridiculous at this point, but that's because people thought kids don't have the cognitive abilities to actually experience depression, because there is a cognitive component. You know, I mentioned a minute ago neurovegetative symptoms, but there are cognitive components, of course, emotional and behavioral components as well. So as you can see, dysphoria, the ability to experience sadness or inability to enjoy things, psychomotor retardation tend to increase with age. Same thing, vegetative symptoms, melancholic symptoms may also possibly be more common in older kids. Negative body image is more prevalent in girls, and mood reactivity, sensitivity to rejection, these are atypical symptoms. There is a subtype of depression, atypical depression, where instead of seeing, for example, insomnia or reduction in appetite, you see an increase in sleep and in food intake, as well as mood reactivity. These tend to be more common in teens, especially girls. And they relate a little bit to borderline personality traits. I don't know how prevalent or accessible firearms are in the US. I'm sure for people, in Turkey, excuse me, I'm sure for people who live outside the US, they see all the mass shootings and they think to themselves, and this is nuts. And frankly speaking, from my perspective, it is nuts. It has, of course, some historical backgrounds for why there are about 350 million firearms in the possession of people in the United States, which makes it so easy to just pick up a gun and shoot. And unfortunately, about 40% of suicides, including in teenagers, are committed using firearms. And there is a sex difference. And so you'll see for male adolescents, for example, about half of all suicides are completed using a firearm, while it's about a quarter in females. In contrast, about 40% of males kill themselves by hanging in the US, compared to about 50 to 60% in females. We all hear a lot about overdose, and that's probably most of the situation, overdose, where you see someone in the hospital having attempted suicide, but they actually account for a much, much smaller section. And it's probably because people can survive an overdose while they cannot survive a more violent suicide attempt. So we heard earlier, Dr. Gomez, what kind of additional clinical information he's interested in knowing. How about you guys? What information as a clinician would you be interested in? And I think this table is informative in this respect, because it tells you some different factors that are clinically relevant and that have been shown, depending on the largest, kind of most well-known studies, to either predict more serious symptoms or to predict greater improvement. And so the plus signs is they're associated with greater improvement. TADS is treatment of adolescent depression study, treatment of resistant depression in adolescents, and this is also, I forgot what it stands for, but it's essentially another pediatric depression treatment study. And so the younger you are in the TAD study, the more likely you are to improve. One particular factor that I feel is relevant, which again takes us back to what I mentioned earlier, but also to Dr. Gomez's question, is the duration of the MDD. I mentioned earlier that I find it, a little difficult to define change. And in looking at just a selected number of studies done in kids and adolescents, I wanted to point out, for example, the duration of symptoms. And by the way, there is also the age, in, at least the first one. You see the kids are about 10 years old, and the mean duration of an episode is 60 weeks. But look at the ranges, ranging from 4 to 572 weeks. There's 52 weeks in a year. 572 divided by 52 is more than 10 years. So it gives you a sense of, like, if I'm seeing a 7-year-old and they tell me I've been depressed for 10 years, how long does it take to figure this out and to figure out what it actually means? This is same essentially thing. It's amazing how consistent the ranges are, huh? Completely different study, 6 to 52. Same thing. And we are under, all clinicians are under pressure to see more and more patients, but we're trying to ask many questions that are clinically relevant, because when I'm seeing a patient, I'm trying to decide, are they going to get better? What are their chances of actually trying to reattempt suicide, to recover, to what kind of services will they need? Well, all of this requires a lot of time to assess. This kind of pictures in a theoretical case of how depression might evolve. People are normal, feeling normal, then they get depressed. Well, I'm not sure I know how to. Okay, then they get depressed, they receive treatment, and then they start recovering. And depending on your cutoff, you may define a response meaning you saw something happen that's clinically significant, but that's different from remission, where I'm back to normal. And defining the two or being aware of the difference is extremely important. And we'll talk about this a little more. And then maybe relapsing. So when someone who's 17 has a 10-year history of depression, is it consistent? Is it up and down? Is it really, are they achieving remission or response? How many of them? All of this is relevant. What I try to do is use, and that's what's recommended, anchors to try to figure out when things started. And so how her dad calls her bro, how much he drinks, how he scares her little two sisters, all of this have been on her mind for about 2 years, ever since I found out he hit my stepmom. So it gives a little bit of validity. But imagine, how much time do I have to sit down and go over each symptom, whether it's been present or not for the entire 2 years? She's been feeling sad since school started. It was about 9 months earlier, because I have a lot of fake friends, and I'm getting talked about. So on the one hand, this is a good anchor, because school starting, of course, for children, major things happen around, the school year, and of course holidays. And so this gives some validity, but then it's also a source of additional information, because struggling socially may be a reflection of her symptom or her disorder and its severity, but it may also be a cause. And things have been getting worse to capture the pervasiveness and the consistency of the symptoms. Now, major depressive disorder, by definition, based on the DSM, you have to have symptoms or the episode for less than a year. For kids, if you hit a year or more, then you go into diagnosing persistent depressive disorder, formerly known as dysthymia. So then the question is, when I tell you I've been depressed for a year or 2 or 5 or 10, whatever, do I know what I'm talking about? And so this is an amazing study. I recommend you guys look it up because it talks about exactly this question. There are many studies that have shown that we are terrible at remembering. Adults, kids, I mean, people don't even remember surgeries. They don't even remember whether they've been hospitalized or not. What they did, I hope you've heard of the Adolescent study. It's a study that's been going on since 1971 or 72, where it's a birth cohort that they've been following ever since. And they've had, it's in New Zealand, and they've held multiple assessments. At each assessment, they actually asked about depression. It wasn't every year, it was every few years, but they asked about depression. And then at age 32, they asked about depression, but also about lifetime history of depression. And they compared it to other cross-sectional studies. So the other 3 studies are cross-sectional, but the Dundon study is longitudinal. And they found that the proportion, the number of depressive episodes that were due to having a depression within the past year was about 40%, that's the 0.4, in the Dundon study, compared to the other studies where it was 52, 53, and 67%. What does this mean? When you ask me today, I'll tell you I'm much more likely to attribute a past depressive episode to the past year compared to if you follow me over time. Meaning, there is a phenomenon well known in epidemiology called telescoping. Everything, and I think the older you get, the worse it gets. For me, everything that happened 6 months ago. And so it is a well-established phenomenon, and it affects recall as well. And I think it's important to keep this in mind because when someone tells you, I've been depressed for 10 years or 5 or even 6 months, you have to ask yourself, how true is this? Because it is important for our management. Other major predictors are comorbidities. And so the more comorbidities you have, in particular anxiety disorders, the worse you do. So I'm not going to give you the details, but she does have comorbid GAD and social anxiety, but no bipolar disorder or psychosis. And of course, in child psychiatry, comorbidity is the rule. I think if you see someone with just depression, you have to question yourself and your assessment. I don't know how often you guys assess for specifically separation anxiety disorder. It's become second nature for me because for me, it helps me further be confident that this is actually depression. It's something more pervasive, persistent, because separation anxiety is a predictor. As you can see, it develops early on in life and precedes all other anxiety disorders, precedes depressive disorders, and even precedes bipolar disorder. And so it's a way I use it as to give myself more confidence that I'm actually, if I'm going to diagnose depression, it's actually true. We did a study a couple of years, well, the study was done between 2010 and 2015, It was a longitudinal study. But we did the latent class analysis to look at how symptoms of depression rated weekly, how they change over time. And we found 3 patterns: people with low levels that stay low, people with high levels of depression at the beginning that remit, and people who don't remit. And as you expect, having, females have a more resistant pattern, so they're more likely to be non-remitters. Negative emotionality in terms of personality traits, having a history of abuse will make you more likely to be a non-remitter, and then having anxiety disorders. So these are some of the consistent predictors of poor outcome. You guys may have also heard about negative, I'm blanking on the term. But there are terms about related to whether a homotypic and heterotypic continuity. Homotypic means if you start with depression, how likely that 5 years, 10 years, 15 years later, you're going to continue to have depression? Or are you going to switch into schizophrenia or bipolar disorder? In kids, we ask the question, if you start with depression in pre-pubertal years, what's going to happen to you when you hit puberty or young adulthood? If you start with depression as a teenager, what happens to you when you hit young adulthood? And these 2 studies have been very informative in this regard, because they showed that if you start with depression in pre-puberty, actually you're more likely to have substance use later on. But as a teenager, you're more likely to have major depressive disorders. And this should make us stop and think, what are we diagnosing? What are the conditions that we're actually making? And is this really what was meant by the DSM in terms of continuity? What's the biggest cause of years lived with disability in children and teens? Cancer, behavioral conditions, heart disease. Come on, you guys, I need an answer. Who would say cancer? No one, okay. Behavioral conditions? 1, 2, 3, 4, 5, okay. Okay, how about heart disease? Okay. Well, half of you haven't answered. You have to answer one way or the other. One more time. Who would say cancer? Cancer. Behavioral conditions. Yes, that's better. Okay, heart disease. Okay, so this is the US burden of disease, but it's actually part of the world burden of disease. And the findings are applicable to other countries as well, for the most part. And you can see in this kind of darker gray here, or blue, wherever you see it, you see how much of the years lived with disability is accounted for by behavioral and mental conditions. Compared to everything else, it's almost equal to all other disorders combined. And I heard yesterday from the presenters about how underfunded psychiatric care here is in Turkey it is. I mean, the speaker, Dr. Support, was making the same comment about Britain, and it's the same comment in the UK. It's just not sexy to talk about behavioral and mental conditions. No one wants to talk about it. Okay, so I hope we agree she has MDD, that behavioral disorders are significant, that suicide risk is increased. So where do we go from here? There are different types of psychotherapy options: CBT, IPT, Parent-child interaction therapy has been studied, especially in younger kids, like preschoolers and very early elementary age school age. DBT has been shown to be effective in kids, teenagers with borderline, but also with depression and a whole host of disorders. Acceptance commitment therapy, if you haven't heard about it, I would strongly encourage you to consider it. It's what's called third wave behavioral therapy. So CBT, behavioral therapy, like basic behavior therapy is first wave, CBT second wave, ACT is third wave. Group therapy, parent training, family therapy, of course. And then in the US, in order to allow kids to be in a less restrictive setting, we offer what's called IOP, intensive outpatient programs, and then PHP, partial hospitalization programs. Both of them are outpatient intensive programs, several hours, either a day, either multiple days a week or virtually every day a week. Who offers therapy, whether you offer it directly to patient or you refer them to psychotherapy? Who offers their kids psychotherapy? That's it? Okay, well, shame on the others then. So let's see what the evidence shows. In this meta-analysis from early or 15 years ago, 35 studies, RCTs meaning randomized controlled trials, and 35 studies, mostly CBT, mostly focused on teens as opposed to children. 50% included clinically diagnosed depression, meaning this is a case you would see in the clinic as opposed to picking them from school or something with some depressive symptoms. 50% used an active control. And fewer studies involved clinic-referred patients. Why is this all important? Because when we talk about, we should send our patients to get therapy, we need to know what the evidence is. We need to make sure that these treatments have actually been shown to be effective and they apply to my patient, the patient I see in my own clinic. So shoot, I lost one of my slides, I think. We'll see if I come back to it. But long story short, the finding is when you look at good quality studies, there is very little improvement with therapy. And you need to treat, the NNT is needed number to treat, it's over here. You need to treat 11 kids to get one positive outcome. Even when you include like poorly done studies, you need to treat 6 kids to get one positive outcome. I mean, imagine you have 11 kids with cancer, you have to treat 11 to save 1 kid. That's where we're at. I realize most of you are clinicians, but I do want to introduce one concept that's a little statistically based, but it's highly relevant to clinicians, and that is effect size. Effect size, long story short, is how much benefit do I get from an intervention, even when I'm comparing different interventions amongst each other. Because sometimes, based on the design of the study, you may not be able to compare apples and oranges. But an effect size is a measurement without a unit. So it's not centimeters or pound or inches. It's actually doesn't have a unit, so it allows you to compare across different studies. How does it work? Very simple. When we're comparing two groups, let's say medication compared to placebo, or one form CBT compared to another active control, essentially, when we're comparing them statistically, we're asking question, is the mean of the first intervention, medication, different from the mean of the second, this is not consistently working, the mean of the second medication. And the difference between these two means is divided by the standard deviation, and that's essentially what the effect size is. Why is it important? It's because every clinical study should report the effect size, because as clinician, it allows you to answer one important question. If I did this study if I gave this intervention to my patient in the clinic, will it make a difference? And there are general guidelines that are agreed upon for an intervention to be, effective, you need an effect size at least medium, 0.5 or more. So keep this number in mind. And here I come back to that other study where I lost the slide. Here it is. In depression, the 35 studies in psychotherapy, they've showed an effect size that is small, 0.34. But I wanted to point out one important thing which is never talked about. And I have nothing to do, nothing against psychotherapy. It's just for the record, my wife is a psychologist, so I'm not bashing psychotherapy. But the effect size in some studies was negative 0.66. What does it mean, the red part here? What does it mean? This means people who received the psychotherapy actually got worse. Yeah, it's ridiculous, but some people get worse. Excuse me? So they had all sorts of psychotherapy tested. Most of them were CBT. But they had other family therapy. They had a couple of studies on like art therapy. So there are different ones. And I don't remember which one was associated with the negative outcome. But my point is, and this is well known in the field, people who do psychotherapy research are not very good at assessing the side effects of psychotherapy. In psychopharmacology, you have to. In psychotherapy, this is not often done. Do you see? Please.
Sorry, Professor. Are we sure about that this is the side effect or side effect due to psychotherapy, or it's just the normal progression of the disease? How can we differentiate that? At the final point, we look at the current condition and the patient is worst, okay, but does it mean that it's due to psychotherapy or just inability to treat the depression and it's going on its own and getting worse?
So I have an answer to this. It's straightforward. It is the intervention. Why am I saying this with so much confidence? It's because I only selected randomized controlled studies, meaning you had a 50-50 chance to receive the intervention or to receive the comparative intervention. So I did not, your concern would be true in open label studies. You don't know what's happening.
Okay, I got it. Fine.
But this is randomized controlled trials. Please go ahead. So I'll come to this. I think it is I'll come to this. If I don't answer your question, let me know. The second one is, you see the R, the correlation coefficient is negative 0.5. And this means, sorry, my pointer is not working. So this means the longer you go without, after the intervention, the worse people are doing. Meaning the intervention, because we always tell patients, I don't know about you guys, I still send patients to therapy all the time, but I tell them therapy, unlike medications, will help you stay well. It will help you from, getting, it's working? Yeah, I'm holding, like. It will help you. Okay. Okay, I'll try. It will help you, from getting worse. But actually, this shows that that's not the case. The more time passes since the therapy intervention, the worse people get. When the comparator group is an active control, then the effect size becomes even smaller. Because now because there's something called attention control. Being in therapy or going to see the doctor to take a pill is not a passive process. Just going there, talking to someone, even if that someone is a wall, will have some therapeutic effect. And so depending on what your comparator group is, the effect may be different. And here, when you use an active control, meaning, even if it's art therapy or problem solving or whatever, the effect size becomes smaller. Studies that use cognitive treatment did not differ from studies that use non-cognitive treatment. This has been an increasing issue. Again, this study is not new, 2006. But for the last 20, 25 years, people have been recognizing that the C part of CBT, cognitive behavior therapy, plays a much smaller role than initially thought. It's the behavioral part, the behavioral activation part, that probably carries most of the effect, especially in depression. Yesterday, Dr. Thapar mentioned, if you were at her talk, that academic centers have better outcomes because people, are doing research, they're more on top of things. Well, they compared studies that were conducted by research-trained therapists versus practicing therapists. The difference was very small. I mean, being in a research setting still has some advantages, but it's not like amazing. This relates to the question earlier in terms of severity. So is the advantage larger if you have clinical disorders versus just symptoms? And the answer is no. Is the outcome better if you provide therapy in a group setting versus individual setting? The answer is no. Is the difference better based on youth report versus parent report? And the answer is yes, potentially. Kids will report more improvement. But that has a big issue, and hopefully, if we have time, we'll talk about it as we move forward. Effect on suicidality, not significant. So if therapy is not great, given the presence of suicidality in our patient, let's consider medications. Again, the concept of effect size applies to medications as well, because remember, it is independent of unit or the intervention itself. And in the United States, I don't know about Turkey, the only 2 medications that are approved by the FDA, our regulatory body, for use in depression are fluoxetine, Prozac, and escitalopram, Lexapro. Fluoxetine is approved for kids 7 to 17, and you can see this is an illustrative study. The effect size is not massive. It's 0.5. And this is escitalopram, 0.27. And it's approved only in teenagers, 13 to 17. So it's not like massive. This study was published a couple years ago, it was a massive network meta-analysis, and the network meta-analysis allows you to compare medications to each other, even though in reality they may not have been compared in head-to-head studies, because except for the Tordia study, no study compared directly different antidepressants. And you can see sertraline came out first. And just so that if you haven't used the CDRS Children's Depression Rating Scale revised, the score ranges between 17 and 117. So it's a massive range, and the difference between the medicine and placebo was 3.5 points. So it's not like, we're not talking again about massive difference. For fluoxetine, it's even smaller. Duloxetine, escitalopram. Escitalopram was actually not significant because you can see the ranges for the other ones. Okay, for sertraline, minus 3.51, and then between brackets, ranging from minus 6.99 to minus 0.04. As long as you have minus on both sides, it's statistically significant. For duloxetine, the second end of the range is plus 0.04, meaning it's not significant. What I would point out is look at the range for the fluoxetine one. So even though in terms of magnitude it's a little smaller than sertraline, there's more consistency in the response. How to prescribe these drugs, I know you do it all the time. I would just like to point out one thing, and that is the average dose in the clinical trials, the average dose is 30 milligrams for Prozac and 15 for Lexapro, escitalopram. I see with learners, they're always starting low, stopping at 20, and kind of nervous about going up. And so I remind them the average dose is 30. This doesn't mean start at 30. I tend to start lower, much lower actually, for fear of side effects. But don't stop too early. I want to hide this slide for a second. How long do SSRIs take to work? Who's the brave person who wants to answer? 1 week? Okay, go ahead. 1 or 2 weeks? Who? Okay, 1 to 2 weeks. Who agrees with this statement? Can you raise your hand if you agree with this statement? Okay, that's a shy agreement, like barely. Like raise your hand high if you believe, yeah, these are your colleagues. So you have 3 people potentially agreeing with you. Who disagrees with this statement? Ooh, people are on the fence. I mean, you cannot be on the fence. Either you agree or you disagree. How long does it take for SSRIs to start, to kick in? No, you answered it correctly.
It take 2 weeks, but it can also be.
I mean, that's why I said 1 to 2 weeks. I'm okay with you, but your colleagues are not okay. But they're not, making up their minds. So what should we say? Any kind, showing improvement. Huh? Sorry, how long? My gosh, what do you guys tell your patients? How long do they need to take the medicine for to start getting better? 2
weeks. It's better to say 2 weeks.
That's okay, yeah. And you said a month? 1 month, that's okay.
Tamamen etkinliğini de So for full assessment for its efficiency, we need at least 1.5 months actually in order to evaluate the efficiency of a medication. And however, in some cases, in early times, there can be some rapid recovery can be also observed. And however, for a real assessment, so for some particular youngster or adolescents, so I think we need at least 1.5 months at least in order to be sure that.
Six to 8 weeks. Finally, someone comes out with the 6 to 8 weeks. So that's what everybody I know tell. I don't have the. So virtually everybody I know says 8 to 12 weeks. And I'm on a mission to dispel this myth because it's just not true. So this is a meta-analysis that looked at antidepressant studies in kids. This is just kids and adolescents, but actually the same is true for adults as well. And so you can see, this is 2 weeks, right? 2 weeks, 4 weeks. And you can see that by week 2, and actually week 1 is not too far off, 70% of the improvement that's eventually going to be achieved at the end, 70% of it is achieved within the first 1 to 2 weeks. And so I think it's very important to tell families, we're not going to wait forever to get better. You're going to start getting better. Thank you. Thank you. You're going to start getting better sooner than you think. In the interest of time, I'll move forward. Okay, so we often talk about combination therapy. We're going to do therapy and medications. A very famous study in the United States, treatment of depression, of adolescent depression study, they gave an SSRI, fluoxetine, versus CBT, versus the combination versus placebo for 12 weeks. As you can see, sadly, only 37% of them met remission criteria. A higher percentage met response criteria, 50%. But then when you look at a meta-analysis of all the combined treatment studies, you see that actually there is no effect on any outcomes, whether it's depression assessed by the patient themselves, by the researcher, impairment, suicidality, both, at 12 weeks follow-ups and at further distant follow-up. How long do we treat depression for? In this study from, a while ago, they treated patients with fluoxetine until they reached remission, and then for 12 weeks, and then those who responded or who were in remission were randomly allocated either to continue on fluoxetine or to switch to placebo. And of course, as you would expect, kids who switched to placebo were more likely to relapse. Median time to relapse was about 8 weeks. By 12 weeks, 66% of kids with placebo relapse compared to 36% on Prozac. Most relapses occurred within 12 weeks. Full relapse was more likely when you had residual symptoms, which is why it's so important to try to achieve full remission. And then relapse was 6 times more common if the kids who had been assigned to fluoxetine were considered responders and switched to placebo. And then perhaps was more common in girls. Now, similar studies have been done using CBT instead of Prozac and showing virtually the same thing. Receiving CBT reduces the risk of relapse. So in terms of duration of treatment, in general, it's recommended that you stay on the medication for at least 6 to 12 months after remission, not after you start the medication, after you remit. And then if you've had more than 3 depressive episodes, you probably will need the medication for years. Or if you've had 2 or more, but with certain conditions, including early onset depression. Those guidelines are based on adult literature. I'm not aware of evidence-based guidelines in terms of maintenance of treatment for kids. What do you do in terms of treatment resistance? So I mentioned Tordia before, treatment of resistant depression in adolescents. In this study, patients were defined as treatment resistant if they failed 1 adequate SSRI trial. And so they were randomized to either receive another SSRI or venlafaxine with or without CBT. So you end up with 4 groups: CBT, CBT, no CBT, and then venlafaxine, fluoxetine, venlafaxine, fluoxetine. And they showed that combined treatment outperformed medication alone. However, patients who received venlafaxine had a little higher heart rate and diastolic blood pressure, and they had more rash. So the recommendation was, if you fail 1 round of SSRI, try another one, because venlafaxine tend to have more side effects. I would say when you have treatment resistance, revise or revisit your diagnosis, look for bipolar disorder or other comorbid conditions. Again, we talked about comorbidity, which is often quite problematic. Evaluate for other medical comorbidities which may be there and may be contributing in a significant way. Try your best at getting your patients evidence-based therapy, which is easier said than done, at least in the United States. We don't get it often where we're able to refer patients to good psychotherapy. And oftentimes, even the SSRI that's being used is at a subtherapeutic level, like I mentioned. Ask about side effects, treatment adherence. In this study I did, we had patients report their adherence, their parents report their adherence, but we also got pharmacy records to see how often they filled their medications and measured their blood level. And you can see I'm only reporting here patients who reported either good or excellent adherence. And you can see that based on their pharmacy record, a bunch of them were actually not taking the medication. So even though they'll tell you we're taking the medication, they were just not taking them. Among them, 14%, we had undetectable blood levels. Additional treatments, which again, I'm not sure to what extent you guys have had to use here, include augmentation treatments, very often now with antipsychotics, sometimes fish oil, omega-3 fatty acids, ECT. In the state where I am at, Texas, we're not allowed to use ECT legally in kids who are 16 or younger. But in the previous state I was at, we would give ECT maybe 1 or 2 kids per year. And then RTMS has gained a huge interest, as well as bright light therapy and ketamine. So typically, we teach our learners, and what we want to do is get collateral information, right? It's key in children and adolescents. You don't want to just rely on the kid. And so far, I've only given you information based on the kid. So here's the mother's perspective. The kid is very inquisitive. She likes video games, likes to eat, is in volleyball. It's hard to find something that she likes and will stick to. She has a small group of friends. She's not the most popular girl. She got A's and B's and 1 C, and her teacher says she's a good student. So really no anger issues, like DMDD kind of issues. And I mean, you hear her mom, you don't even think she has depression. Mom denied depressive symptoms. She's in a good mood. Her confidence is 7, 8 over 10. She has been sad following, this was a really tragic school shooting in Texas a couple years ago. And she told her mom that she felt not loved, because her sister is involved in sports, and sometimes mom has to go travel with the sister, and so she feels kind of left back. So how good are parents and children at agreeing on reporting symptoms? And of course, it varies by disorder. In particular, for depression, it's an internalizing disorder. So the parents, and that's what is meant by internalizing, the symptoms are felt internally for the most part, as opposed to ADHD, when the kid, is bouncing off the walls, everybody can see it, it's externalized. So for internalizing disorder, agreement is lower. And as you can see, the kappa in this, column here is an indicator of agreement between two informants, whether it's two clinicians, a parent and a child, and anything that is below 0.4 is pretty abysmal. You can see that the agreement is actually pretty poor.
We have only 7 minutes left, Dr. Calarge. We have only 7 minutes left, maybe for some Q&A.
At 5 weeks, she's much better. She reports virtually resolution of her symptoms. I'll go a little quick, through this. At 8 weeks, again, she feels good, and she's able to kind of move on with things now, but which is different from before. She's sleeping better. Remember, at baseline, she said she had no sleep issues. At baseline, she said she doesn't like being short. Now she feels it's actually an advantage because she can find better hiding places. One issue that psychiatric care in children has struggled with, especially with depression, is lack of consistent findings in terms of efficacy of medications in depression in children. When you look at this slide, you see that the response to medications is actually, in kids, is almost equal to adults. What's different is the rate of response to placebo. So this kid, without actually medication, improved and without therapy, drastically improved. I saw her in 5 weeks. She could have improved 2 weeks later. I think this raises, from my perspective, the difficulty of how much people report things, whether how bad their symptoms are or how better they get, just because of what's called social desirability, meaning I want to please the person I'm talking to. I'm sure you guys have been hit by TikTok like everybody else is, and TikTok is kind of just an example of social media in general. It's not uncommon where you see patients coming to you and it's like they've memorized the DSM. They know the symptoms better than you do, and they'll tell you. I had a kid not too long ago who asked to spend the time talking about why she has autism, and on her way out, she said, next time we'll talk about borderline personality. I promise, I'm not making this up. And so this adds a challenge for us as clinicians. What do we believe? On the other hand, you have stigma against mental illness, and so you have to navigate a very difficult situation. And you have teenagers or kids who need to feel also well. So navigating all of this can be quite a challenge. In sum, for me, I think of myself when I'm interviewing kids as an investigator, trying to figure out what is true, what's not true, and getting, of course, frustrated because I don't always have the answer. They keep you honest often because I feel you cannot doze off while you're talking to kids. I mean, they will call you out, they'll disengage, and you know that you mess up. Coming back from it can be an issue. Understanding what they mean to say and separating the natural course of the illness, the gentleman asked earlier, from a treatment response can be particularly challenging. And so with this, I end my talk, and maybe we have a couple more questions minutes for questions.